So good afternoon. Hopefully we'll just slow down a little bit. So I've been asked to talk about state-of-the-art imaging for safe aortic repair, and I'll say to you that this is mostly about safety rather than state-of-the-art. And it also relates almost purely to the endovascular repair of an infrarenal abdominal aortic aneurysm, but the principles can be applied to the thoracic aorta. And I think you have to divide it into three sort of isolated but related steps, and that's the preoperative, the intraoperative, and the postoperative phases of a repair. And then we have to decide what are the potential harms for the patient or the operator. And we have the traditional ones, which are the radiation, the nephrotoxicity, and the radiation is a problem particularly with prolonged procedures, the complex EVARs, the 𝗔𝗍𝗄s, and that when you're doing them recurrently, is a big problem for the operator as well. But I think the bigger problem for the patient is treatment failure, and that can be put down to poor planning, inaccurate deployment, and of course we know that the devices themselves are just not as durable as an open repair. So in the preoperative phase, well, imaging, we know, I'm not going to teach you very much here. You can use two imaging modalities. CT is the workhorse. But I would try and stress at the bottom of this slide here, a pointer, that I think you should have a protocol that looks at the whole aorta with CT, and that's because in published series, up to 25% can have a tandem aneurysm, 20% can have a significant extravascular finding. And what I used to find is if we just image the abdominal aorta, if they had a juxtarenal or a pararenal aneurysm or a thoracoabdominal aneurysm, they had to go back for another CT. So it avoids having to repeat. So it is really important when you have your preoperative imaging to use the multiplanar reformats. And that just not only assesses whether the patient is suitable, but it enables the planning, and not just the planning of the device and which device is appropriate, but you need to try and imagine how the device will go in and how it will lie, and it also gives you an opportunity to calculate the optimum gantry angles so that you can deploy the device accurately. The intra-procedural imaging is where we've seen some more recent technological advances. I mean, the minimum requirement here is to have a good quality 2D fluoroscopy unit, which does digital subtraction angiography and allows angulation of the gantry. But we've seen more recently that we've progressed to fusion imaging, and this is a sort of 3D, 2D overlay imaging where you create a 3D map from the CT or MR, and then you sort of integrate it. I mean, it's a sort of computation algorithm, and you create the map manually, and then you fuse it with your live image, and it gives you a map of a 3D map while you're screening in 2D, and I'll show you a picture of how it looks in a minute. And I assume most people may have used it. There are two main systems. There's a sort of manufacturer-based system, which requires you to sort of upload the CT data into the console in the control room, and then you manually create the map. And then there's a cloud-based system where you upload the 3D data to the 𝗖𝗲, who is the company who operate this, to their database, and they actually automatically create the map for you. The manufacturer-based system requires you to have a hybrid room, whereas the cloud-based system, actually you can use it on any fluoroscopy unit, even a mobile one. So this is the sort of image you get, and of course most people would think it applies to complex repair because you can see that it gives you a roadmap of where the branches may be, and so it makes cannulation easier, and it gives you much more confidence of deployment of the graft and where the fenestrations need to be. But there are actually benefits for both complex and infrarenal deployment because it gives you much greater accuracy. And you can see from this example here, in the old traditional way where we used to sort of do the angiogram and then we'd draw where the renal arteries are on the screen, and then we'd deploy it, you can see that actually we're missing out on quite a significant length of neck. And so, in shorter necks, that could actually compromise the repair in the long term. The other thing is shown, as I mentioned, it makes cannulation of branches easier in complex repairs. It has there is increasing evidence to show that it reduces procedure times, it reduces the volume required, the volume of contrast required, and it reduces the radiation dose. There are also new adjuncts to sort of the fusion imaging. We've heard that people use IVUS, and there's some optical imaging techniques that are also, beginning to come into use, and we'll hear about that tomorrow from 𝗘𝗴𝘆𝗀𝗶𝗄𝗆. Sorry, I might have jumped on there. So for the final phase of imaging is the surveillance, the post-operative phase, and this is mandated lifelong or appropriately lifelong in all guidelines, and really it's to make sure that the EVAR repair is because it's not as dural as open, we need to make sure that it lasts as long as possible. Your surveillance protocols are individualized, but one of the criticisms I have for them is that they are uniform, and so they do not actually recognize who may need enhanced surveillance, who is at risk of failure in this sort of mid to short term. We know there are some subanatomical features that might actually guide us, but interesting, there's a group in Japan who are now looking at CT texture analysis just of the gray level in the aortic sac, and they use AI computational methods to assess this, and actually this is already shown to be more accurate than the conventional clinical and anatomical findings that we currently use. This is our local protocol. We do a CT and X-ray at a month. We then do the same at 12 months with an ultrasound, and if there's no adverse features, they go to annual X-ray and ultrasound. If there's any adverse feature, they then usually have a repeat CT if they haven't had one recently. They get discussed at our MDT, and then if there is a decision to do something, they are investigated further, or either it's obvious or they get investigated further, and often there's a decision to do nothing because the seal zones aren't compromised. So for example, the most common scenario being that the sac's still growing, the seal zones aren't compromised, so we just decide to keep them in enhanced surveillance rather than do anything for the time being. I think when you're doing post-procedure CT evaluation, it's very, very important to still use multiplanar reformat analysis, because, last year or 2 years ago, we asked a medical student, or I asked a medical student to look at 50 consecutive elective EVARs done who were all on IFU preoperatively. And what they found in the post-operative 1 month CT is that in 13%, at least 20% of the proximal seal zone had not been used because of low deployment. And in fact, that made 8% not on IFU post-deployment. So I think it's very, very very important to make sure that at least at your 1 month CT, that your repair is on IFU after you've done it. Finally, we all know that it's very difficult to sometimes to determine why a sac is growing, because on CT it's not always obvious. We have these other imaging modalities, and I would say currently, if you're looking for an endoleak, contrast ultrasound remains the most accurate. And you can see on this image, this guy had his EVAR in 2017. It was done at 6 centimeters. It's now approaching 9 centimeters. Nothing seen on CT. Even with delayed imaging, nothing makes seen. But actually, he's got a massive IMA type 2 endoleak. This was only done last week. So in conclusion, I'd like to say to you that imaging is absolutely integral for safe aortic repair. There are technological advances that make it safer for both the operator and the patient to optimize outcomes and try and ensure the most durable repair. And I would also like to just reiterate that surveillance is equally as important as the planning and the deployment phases. Thank you.